A very good morning to all of you, and welcome to the Shri CPD program organized by the Society of Health Research and Innovation. And Shri is a national CPD provider. So today morning, I would be like to give your attention to the few housekeeping rules. Please note that this webinar is being recorded. So please keep your mics muted and video is switched off at all times. And as you know, the webinar link will be available from 9 a.m. and 9:50 a.m. for you to join in. And no late attendees will be entertained thereafter. And each attendee should attend until the end of the webinar to obtain the certificate for the CPD points. And the CPD points are strictly adhered to the NC-CPD guidelines. So, and also we would like to thank you in advance for strictly adhering to the CPD regulations and for your kind compliance. And this CPD is maintained in the standards of the CPD program conducted by Shri. And so we really appreciate your adherence to the guidelines. And a little reminder about asking questions. Please note that the question time will be at the end of the webinar. And if you have any question, please type it into the chat box. And please make sure that you change your chat settings to all panelists and attendees so that we can visualize, we can see your questions and that your question can also be answered. And if you have very specific questions about your situation, please email us on office13@gmail.com. So before we move on to today's topic, there is a small reminder on completing the link. So link on obtaining the CPD certificate will be visualized in the chat by 10:30 a.m. So please make sure that you fill in the link and give your feedback to the link, or else we would have issues in you will have issues in obtaining your CPD certificate. So moving on to today's topic, today's topic is very eminent topic, which is on common cardiac emergencies. And the facilitator today will be Dr. Amila Walawwatta, who is a consultant cardiologist from the Colombo South Teaching Hospital. So we would like to welcome Dr. Amila Walawwatta, the consultant cardiologist from the Colombo South Teaching Hospital, to the CPD program organized by Shri. And over to you, sir.
Thank you, Tatsara, for your kind words of introduction, and very good morning to all of you. So I'll be talking about on few cardiac emergencies, especially the management perspective. It's a fairly extensive topic. I will not be able to cover thoroughly within a period of 1 hour. So I'll be just touching on few areas which I thought are important. So I'll be discussing about 3 key topics. Okay, so first I'll be touching about the management of hypertensive emergencies, then about acute coronary syndrome, mostly acute ST elevation myocardial infarction, which is the highest risk category in acute coronary syndrome. Then touching briefly about management of acute decompensated heart failure. So let's begin with hypertensive emergency. So blood pressure is quite a common entity in our clinical practice, and it constitutes hypertensive emergency when you got severe elevation of blood pressure. For example, over 180 systolic and 120 millimeters of mercury diastolic. Severe elevation of blood pressure along with evidence of impending or progressive target organ dysfunction. So we will discuss what are the target organ dysfunctions that we will encounter. So you need to have the evidence of target organ dysfunction plus severe elevation of blood pressure. If you got both of that, you can call it a hypertensive emergency. If you just have severe elevation of blood pressure but no target organ dysfunction, you can call it hypertensive urgency, where the blood pressure reduction can be done more gradual fashion. But in a hypertensive emergency, you need to act in a bit more swift way. So what are the target organ dysfunctions that we will encounter? So it can affect different organs. For example, when it affects the brain, patients can get acute strokes, intracranial hemorrhages. You can have a hypertensive encephalopathy leading to agitations and restlessness and altered level of consciousness. When it affects the eye, patients can have papilledema, fundal hemorrhages, exudates in a progressive manner. And when it comes to the heart, it can affect cause myocardial infarctions. When it involves main vessels like aorta, it can cause aortic dissection. With regard to heart as well as the lungs, patients can have going to pulmonary edema. The acute kidney injury causing acute renal impairment. In a pregnant patient, it can lead to eclampsia and so on. So what is the pathophysiology of hypertensive emergency? Severe elevation of blood pressure can cause mechanical stress on the vessel walls, leading to damage to the endothelium, leading to a pro-inflammatory cascade of events. This results in increased vascular permeability, platelet and coagulation cascade activation, leading to fibrin clot deposition inside the vessels, also causing vasoconstriction at the end, leading to hypoperfusion at the level of target organ. So that is what happened in the pathophysiological point of view. Along with that, you get another important phenomenon operating, which is loss of autoregulation. Now, autoregulation is a phenomenon. If you have fluctuation of blood pressure, for example, the blood pressure drops, the vasomotor tone get adjusted to maintain perfusion. In a patient who have slightly lower blood pressure, the vessels dilate, maintains the perfusion. When the pressure goes up too much, the vessels constrict. Still, the perfusion is maintained at the same level. This is called autoregulation. I mean, the vessels adapting to changes in blood pressure. But this is lost in a patient with a hypertensive emergency, because if you drop the blood pressure too rapidly, the vessels will not adapt, and it will result in poor organ perfusion, will worsen the target organ dysfunction as well as damage. So you need to be careful. You need to reduce the blood pressure also on one side. On the other side, you need to be careful because you need to understand that there is autoregulation. So how much to reduce and how fast to reduce will depend on individual conditions. So we will discuss about all that as we go along. So in a patient with hypertensive emergency, of course, you will assess the symptoms. What are the symptoms of target organ dysfunction? You take a history why the blood pressure became uncontrolled. Is there issue with compliance? Or is there issue with dietary compliance, especially salt intake, etc.? And you measure the blood pressure correctly using the correct methodology. And you examine him physically to look for target organ damage, as well as you look for evidence of any primary causes, for example, coarctation of aorta, where you have the radioradial delay, etc. And also target organ dysfunction. For example, if you're suspecting a dissection, you check for blood pressure difference in both thumbs. So you'll have to do a thorough examination. With regard to investigation, you'll be doing basic investigation, especially renal function tests, a full blood count, a urine analysis looking for proteinuria, a ECG, and where relevant echocardiogram, troponin I, BNP level, X-ray, so on. If you suspect specific conditions like aortic dissection, you might need a CT aortogram. If you're suspecting ICH, a CT brain, the suspect will be a secondary cause, especially endocrinological issues, you might need to do some assays. So investigations depend on the clinical conditions and the complications that you suspect. So I've already briefly told you, the challenge is you need to reduce the blood pressure here to prevent further damage to the endothelium, stopping this catastrophic cascade of event, which damage and worsens target organ dysfunction. On the other side, you need to understand that there is loss of autoregulation. So you need to reduce the blood pressure carefully in an accepted manner to prevent further worsening, damage, or dysfunction of target organ tissues. So general recommendation, these recommendations changes according to specific situation, which we'll discuss as we go on. But in general, you try to reduce the blood pressure in most of the situation by about 25% over the first 1 hour. How you do it, we will discuss. And then over the next 2 to 6 hours, you will reduce it further, but not to less than 160 systolic and 100 diastolic. And you maintain that up to the next 24 hours. The important key phenomenon is there is autoregulation here, right? So in most of the patients, unless specified by a specific complication, which we will discuss, you try to reduce the blood pressure gradually, 25% for first 1 hour, then over the up to next few hours, up to 6 hours, you gradually get it down to 160 and 100 range. And you maintain that for the next 24 hours. Then only you will reduce it further using oral medication. But for the initial part, you will have to try it with intravenous medications. So I've told you that for specific conditions, this general rule doesn't apply. There are specific conditions where you would act differently. What are those conditions? So this chart will elaborate you. For example, if you got a patient with aortic dissection, as specified here, you don't want the dissection flap to spread further because of high blood pressure. So you want to reduce the blood pressure further. So in a patient with aortic dissection, you would target a blood pressure. You want to drop it down to around 120 systolic. Sometimes even 100 is acceptable. Something in that range is your target in a patient with aortic dissection. So it's in that particular situation, you would be more aggressive in managing the blood pressure. On the other side, if you got a patient with an ischemic stroke, the scenario is completely different. In that setup, if you lower the blood pressure in a patient who has brain ischemia, you will worsen the ischemia further. So if you're not considering a thrombolysis for that patient, then a blood pressure, systolic blood pressure of even 220 would be acceptable. So you don't want to reduce it below that, unless you are going to consider thrombolysis in that type of patient, because your treatment will worsen the brain ischemia, right? So unless it's all very high range, you will be acting very cautiously. But if you're considering a thrombolysis in the same patient because of early presentation, then you don't want the patient to end up in a catastrophic ICH. So you would reduce the blood pressure to around 180 range, still not to normalized range, around 180 range, then you can consider thrombolysis. Similarly, in a patient with a hypertensive encephalopathy, you also always don't want to reduce below 180. In a patient with acute myocardial infarction, you will reduce the blood pressure to around 160, 150 range, but you don't want to reduce it further all of a sudden, because that can worsen the coronary perfusion, which is already the issue in acute myocardial infarction, right? On the contrary, if you got a patient with a intracranial hemorrhage, you will want to reduce the blood pressure a bit more, maybe to around 140, 150 range, because high blood pressure will worsen the brain bleed. So there you are a little bit more aggressive in reducing the blood pressure. So specific conditions, we will deviate from the general guidelines, which I specified to you, 25% reduction up to 161 rate, 160, 100 range is a general recommendation. But in specific situation, you will have to adjust accordingly as the condition demands. So in a patient with aortic dissection, you reduce the blood pressure down to 100, 120 range, and also control the heart rate to around 60. And because we don't want tachycardia, we don't want hypertension, so we will use a medication which will control both. For example, IV labetalol or IV esmolol are the preferred agent of choice in a patient with aortic dissection. If you got an acute intracranial hemorrhage, again, you'll be a little bit more aggressive. You reduce the blood pressure to around 140 range or 150 range to improve the functional outcome. You don't want the hemorrhage to expand further. So here the medication we use, which is recommended, is calcium channel blockers like IV nicanidipine. And we are not as aggressive as in treating dissection, but also here we are a bit aggressive in getting down the blood pressure quickly to around 140 range. In a patient with ischemic stroke, on the contrary, we will treat only very high elevation of blood pressure. For example, about 220, 120, we would treat. But anything below that, we will not treat unless we are considering thrombolysis, in which case we would bring it to around 180 and 110 range with intravenous medication, preferably again IV nicardipine. In a patient with acute myocardial infarction and pulmonary edema, again, we don't want too rapid correction of blood pressure, but we would want to reduce the afterload, reduce the stress on the heart. So we want to reduce it, but we don't want to augment, worsen the coronary ischemia by rapid blood pressure reduction. So you get it out around 160 range or 150 range or slightly around that area. with preferably with a vasodilator like GTN. So we will reduce to around 25% in the first hour, then we over the next couple of hours or so, we will reduce to around 160 range. So pheochromocytoma crisis is also another condition. It's not a common cardiac emergency, it's a rare thing. But again, the management principles are a little different. Here you get excess catecholamines. So, but if you use a medication like a beta blocker here, what it will do is it will get dislodged. The excess catecholamine will get dislodged from the beta receptors and it will attack the alpha receptors, causing vasoconstriction. So in a patient with pheochromocytoma, you have to be very careful not to use beta blockers. Instead, first use an alpha blocker. Make sure that there is vasodilatation first, because if you want to use a beta blocker in this patient, you can worsen the hypertensive crisis. The preferred medication here is IV phentolamine, which blocks the alpha receptors and control the blood pressure. So I'll not be going into detail about the dosing of specific agents. Those days, naive nitroprusside was used, but nowadays it's not that recommended because of fluctuation of blood pressure. Sometimes the pressure can crash in unpredictable ways. So we would go for modern medications, labetalol, Olnicard, DPN, GTN, in different as the situation demands. So let's move on to the next topic. So it's about acute coronary syndrome. In acute coronary syndrome, the most dreaded emergency is acute ST elevation myocardial infarction. So I'll be touching briefly about the concepts, the drug dosing and certain situations where you have to be careful, just to refresh your memories so that you keep kept updated. So in a STEMI, the most important perspective is the patient symptoms, because your ECGs can mislead you at times. So you need to understand, first thing with regard to STEMI management is high index of suspicion in a patient with suspicious history. Because if you just relax by looking at the ECG, you can make a very bad mistake. So when evaluating a chest pain with regard to acute coronary syndrome, you need to analyze the nature of the symptom. The nature of the symptoms mean, is that a pinpoint pain or a sharply demarcated, very pointed area of pain, or is it a visceral pain? The pain can be described in various ways. Some people say it's a burn, some people would say tightening, some people would say heavy. So in an area which is compatible with angina. So it can be center of the chest. Many people would, spreading up their neck, the lower jaws, the shoulders, the left arm. In whatever the area, pain is a poorly localized pain. Sometimes it's described as a burn, sometimes as a pressure, sometimes a pain, sometimes as a tightness. The description would vary. But the other important thing is it would last beyond 20 minutes. So if you've got a patient comes and say, patient, going off in about a second or two, you don't have to worry. But if you've got a patient who says, my pain has gone beyond 10, 15 minutes, now it's beyond 20 minutes. And in whatever the area which is poorly localized across the chest, the neck, or the lower jaw, the shoulders, arms, you have to suspect that this patient might be having a acute coronary syndrome. So that is very, very important in your patient management, because sometimes you find a ECG is fine, but the patient history, patient's face is ill looking, patient is in pain, he seems to be in agony, and the pain is going on for beyond 10, 15 minutes, then you have to be very suspicious and deal with the experts. There are things which can be done in a bit more quicker way than repeating another ECG. I think you need to liaise with the cardiologists or the experts who are there in sorting out, because certain investigations will help you to make a quicker diagnosis and to save the patient. So don't relax, just because of the ECG. Just always focus on the history and the state of the patient. Look at the patient face, look at the symptoms and work out on those. I will show some examples how that might help you. So STEMI definition is you need to have chest pain, which is compatible with ischemia. You need to have evidence of ST elevation, which is persistent in 2 or more leads, which indicates complete occlusion of one of the main vessels supplying the heart. So you can, instead of ST elevation, in some patient, you can have a new onset left bundle branch block. The other tool which is very useful to make a quicker diagnosis is the availability of echocardiogram, because sometimes in a patient with a suspicious history, even if the ECG doesn't show, if the patient is in pain, patient is in ongoing pain, the echo will immediately show the regional wall motion abnormalities, and you can immediately start your treatment just by a quick echocardiogram. So if in a patient who's ill looking, I wouldn't recommend just waiting for another ECG in half an hour. I think you need to act quickly, use other tools which are available, and make a quick diagnosis, and to go ahead with patient management. So you can see the way the ECG evolves. This is a normal looking ECG. You can see the first thing which will happen in a STEMI is peak of the height of the T waves, the hyperacute Ts. Then you get the ST elevations coming up. It typically is like this pattern, the convex upwards, but even concave upwards is possible. You might get reciprocal ST depression. So in the opposing lead, you might get, for example, in anterior STEMI, you will get ST depression in the inferior lead, but that will not happen in every patient. If it is there, it is suggestive, but if it is not there, it doesn't mean that it is not a STEMI. So always look at the clinical history and work out on things along with the ECG. In a patient with suspicious history, even just hyperacute T is good enough for you to activate the treatment arm, or any type of ST elevation. So it's always, ECG or any investigation is complementary to the clinical picture. You need to match up and make overall judgment with regard to the treatment options available. So over time, you will see the STs coming down, the T is getting inverted, the Q is forming. So this is the natural evolution of the ECG. So cutoffs are there defined for genders and age categories, which you don't have to buy heart much. So ECG localization is there to describe whether it's a septal, anterior, anteroseptal, anterolateral, extensive entry, etc. But you don't have to buy heart, it's just for academic interest. So I told you how deceptive it can be. So this is a patient whom I've had, I think it was on the 24th of April, just 2 or 3 weeks back. A patient with chest pain came to one of the private sector hospital, 2 a.m. in the morning. I got a call saying there's a patient with chest pain, central pain is there. The pain is ongoing for about 1 hour or so. So ECG, this is the very first ECG. You can see very mild STs just going up slightly, but then not that significant. There are no reciprocal changes. It was 2 a.m. in the morning, just waking up from sleep. I was not extremely interested about the ECG appearance much. There's the repeat ECG. You see very no ST elevation at all, very mild ST depressions, maybe 0.5 millimeter, nothing much. So this was the ECG where I was called. So I was not that keen to wake up at 2 a.m. in the morning and to visit the patient. But then again, the person who was with the patient, the medical officer, was a little bit pushy. She felt that the patient is in pain, was a bit ill looking, and there was ongoing pain, which prompted me to, to break up with my sleep and go and visit the patient. When I went there and saw the patient, I just took the patient to the cath lab immediately and just did an echo just before I did the angiogram to realize the entire anterior and the apical walls were hypokinetic. EF is around 30%. Did the angiogram to realize completely occluded left ventricular descending artery. It's not typically a De Winter pattern. You don't see much of a hyperacute TCF, very mild ST depressions. So important thing is the medical officer who saw the patient's real picture. She saw that the patient is in pain, the ill-looking phase, and ongoing pain. So that is why it is important. You just manage the patient mostly based on the clinical symptoms and tally with other tools. For example, if you just wait for the ECG, take another ECG in 1 hour, waiting for the cues to form, the STs to go up, you'd have wasted valuable time and losing the myocardium. And that may be the only window that you could have salvaged the patient by quickly attending to the patient. So it's always one tool per se is not good enough for you to make an overall understanding of the patient. So you always need to tally with the patient clinical symptoms, use other tools in a patient's where the clinical conditions demands more action. So always don't forget the history and the patient's symptoms, right? And use other tools when you think that the situation is a STEMI or a possibly acute coronary syndrome. Use disturb the available specialists who are there. Use other tools like echo and etc. and try to save the patient. So that because the medical officer look at the patient was more more worried, more concerned about the patient's conditions. It helped me to save this particular patient because otherwise I would have, if I did the angiogram next day morning, I would have got into real trouble, may not have been able to save the patient's life. So always history first, tally with the history, use tools as per the conditions demand. So in a STEMI, we call time is muscle. You need to really act really fast. So what is first medical contact? Is the place or is the situation where the patient and whoever the medical professional is in touch, where a ECG can be done and emergency treatment like either defibrillation or thrombolysis can be offered. So that is the definition of first medical contact. So in a patient with STEMI, the goals of management is immediate reperfusion, right? So you see the patient, you make the ECG, make a diagnosis, you want to act very quickly. So here, time is the key and time is muscle. So in a patient with chest pain, if there are ST elevations, you need to offer immediate reperfusion. So the best reperfusion therapy is a primary PCI, but you need to do it very quickly. You need to do it within a couple of hours from first medical contact, which includes the transit time taken to the cath lab and the time taken to start the procedure, cross the vessel, balloon the vessel, and open up and establish some kind of flow. So that total duration needs to be within 120 minutes. Earlier the better. If you can do it within half an hour, perfectly better. But if you're beyond 120 minutes, you need to consider other modes of reperfusion like thrombolysis. So if you can do within 120 minutes, including transit time, go ahead and do primary PCI. If you can't, consider thrombolysis. To give thrombolysis, you need to have a suggestive history. Just pain more than 20 minutes. Primary PCI not possible within 120 minutes. Is suggestive ECG. You need to exclude all the exclusion criteria. Then you can go for thrombolysis. What are the other supplementary treatments or medications we use? We use oxygen, but don't just give oxygen for every patient. It will cause vasospasm and it will worsen ischemia. So you will only give it an indicator patient if the saturation is less than 90%. That's the indication to give oxygen. So if you got a saturation 96 for every MI, don't give oxygen. That is incorrect management. Nitrate should be given for pain relief like GTN, but make sure that the patient is not hypotensive and be cautious and try to avoid in situation where there's RV infarct, severe aortic stenosis, or the patient has been on something like sildenafil for erectile dysfunction within the last 24 hours. Again, that's a situation where you can have worsening of hypotension. So try to avoid in situations where there is hypotension. Can give morphine for pain relief like 5 milligrams of IV morphine. So with regard to antiplatelet management, which probably I should have discussed before thrombolytics, that's one of the earliest treatments which we offer. So we, irrespective of age categories, renal function, is the loading dose is same around 300 milligrams, and you make your maintain dose of 75 milligrams a daily. But important feature is you ask the patient to chew the tablet, not to swallow, chew the tablet so that buccal mucosa will absorb it quick. So loading dose is same in every situation, irrespective of age. But with regard to clopidogrel, this is one of the medications which we use in acute coronary syndrome, but there are better medication to use. We will discuss it separately, but this is a medication what we have in government sector. So most of the government hospitals still uses clopidogrel as one of the main modes of antiplatelet therapy. So the dosing depends whether we are going for thrombolysis or for primary. Because in a patient with thrombolysis, the bleeding risks are higher. So dosing is less accuracy, and it's even more cautious in the elderly. Right? So general dosing is 300 milligrams in a patient who are younger, less than 75 years, followed by 75 milligrams a daily. This is a patient who's considered for thrombolysis, right? But in a patient who has over 75 years, we omit the loading dose, just give around 75 milligrams, which is actually the maintenance dose, and you go ahead with thrombolysis. So this, with regard to thrombolytic group, you're a bit cautious and even more cautious in those who are older. But when it comes to primary PCI, the dosing is a little bit more aggressive, right? So you should go up to 600 milligrams of loading dose and a maintenance of 75 daily. But in elderly, you may go for a 300 milligrams loading and go ahead with primary. Now, primary, you can give a little higher dose because you're not going to use thrombolytic. The bleeding risks are relatively lower. So you can go for a higher clopidogrel dosing. But one of the main issues with regard to clopidogrel is that it's a pre-drug. It needs to be metabolized and activated to a secondary product for the pharmacological effect. So it will take few hours. So which is the main issue with regard to using clopidogrel for a patient, especially for a primary PCI, because you end up putting a stent, you're given clopidogrel, and your stent is in place over the next 30 minutes or 1 hour, and the clopidogrel has still not got going. So that is a concern with regard to using clopidogrel in a patient who's managed with especially the PCI arm. So that is where the modern world, the medications we're using either ticagrelor or sometimes prasugrel as first line medication, because the medication will act much quicker than clopidogrel. But however, at present in the government sector, we just have to deal with clopidogrel. So these are the way the dosing is adjusted as per the conditions. So these are the medications. So prasugrel is a good potent antiplatelet therapy, which is useful in management of STEMIs, which is used in most of the developed world. But however, you will avoid that in a patient with a previous stroke. That's an absolute contraindication. Also, you try not to use it in those who are underweight, less than 60 kilos, or who are older than 75 years, right? So you would use it in a patient who has well built over 60 kilos and less than 75 years, you would go 60 milligrams of loading and 10 milligram daily. And you would like to avoid in patients who are older than 75 years, but if you compel to use it, you have to use half dose of 5 milligrams per daily as maintenance. But in young patients, fit, not underweight, no previous strokes, you would go for prasugrel. Ticagrelor is another medication which is very popular in our setup, especially in the private sector. Even in elderly, you can give about 180 milligrams loading and give 90 PD as a maintenance. It's a little bit expensive, but it's a very good medication, especially in a setup of primary PCI, because drug will act quickly, and then when your stent is in place, the drug will effectively prevent the risk of stent thrombosis. So we have talk of thrombolysis, and this is a bit of absolute contraindication with thrombolysis in those who are being considered for thrombolysis. So in a patient with past ICH, you will not consider thrombolysis. Stroke, even ischemic stroke within 6 months, you will not consider central nervous system tumors, recent major trauma within the 1 month, an aortic dissection, you will not use it. You will not use it in patient with bleeding that this is, but those having menses can be considered. It's not a contraindication for thrombolysis. If you've done a non-compressible puncture within 24 hours, for example, lumbar puncture or liver biopsy, in that setup, if a patient gets STEMI, you will not consider thrombolysis. Visceral bleed like a GI bleed within past 1 month, you will not consider thrombolysis. So these are some of the contraindications. So these are different thrombolytics which are available. So with regard to thrombolysis in the elderly, you have to be very careful. There are specific precautions you need to take. You will not be giving the loading dose of clopidogrel. So if you're using clopid as one of the antiplatelets, you will just give the maintenance dose of 70 milligrams. Dose of thrombolytics is half of the adult dose. Half dose of tenecteplase is given. Streptokinase, of course, you can give a normal dose because it's a less potent thrombolytic than tenecteplase. With regard to enoxaparin, we will be discussing how much to give. In elderly, we don't give the bolus of enoxaparin. And even the enoxaparin dose, which is given after thrombolysis, is 0.75 mg per kg, which is 75% of the normal adult dose. So you would use less dosing in thrombolytic group in the elderly. So these are some of the thrombolytics. You have streptokinase and you have tenecteplase. Tenecteplase has a much higher reperfusion, around 60 to 70. Streptokinase only 30 to 40%. With regard to enoxaparin, so in a patient with a normal or better renal function, GFR more than 30, then you can give enoxaparin as a preferred antithrombotic. You don't need to monitor the APT levels. So if the patient is less than 75 years, you along with the thrombolysis, you give an IV loading dose of 30 milligrams. Then you give a maintenance dose of 1 mg per kg just 15 minutes after thrombolysis, and you continue with twice a day. But the loading dose and the maintenance dose added together should not exceed 100 milligrams. In those who are older, no IV loading bolus, only the maintenance dose of 0.75 mg per kg initial dose, and then repeat twice a day. In a patient with poor GFR, less than 30 ml per minute, you prefer to give heparin. If you happen to give enoxaparin, you should give once a daily dosing. So after thrombolysis, what are we going to do? We're going to assess whether the reperfusion is successful or not by doing ECG 60 to 90 minutes after the thrombolysis, looking for 50% ST resolution. If that is unsuccessful, you would immediately consider primary PCI. Actually, the best way to manage as per the guidelines is to give the thrombolysis and transfer the patient to the nearest cath lab centers where you do the ECGs just 90 minutes or 60 to 90 minutes after the thrombolysis time, and do the ECG. If the STs have not resolved, immediately take to the cath lab and open up that vessel which is not got opened by thrombolysis. Those who have successful thrombolysis could have the angiography next morning in a bit more leisurely way as part of pharmaco-invasive strategy. So in ECG, you need a patient set up with STEMI, you need to act fast. From the admission within 10 minutes, you should have the ECG, and the ECG need to be read and diagnosed made within 10 minutes. Over the next minute, if you consider thrombolysis because the primary PCI is not feasible, you should give the thrombolytic over the next 10 minutes. So within the admission time to thrombolysis, it need to be within 30 minutes. In a setup where you can refer to the patient with a primary PCI center, have the primary PCI within 120 minutes of first presentation, you should go for primary PCI. If the center has of course, a functioning 24-hour PCI service, that should be the first way you should be able to do the procedure within 15 to 20 minutes and save the patient life. So let's go and discuss briefly about acute heart failure management in the emergency department. So in acute heart failure, there are few clinical entities we can do. Now, acute heart failure most of the time happens in a patient with poor pumping function of the heart, but it can happen in other situations also, for example, as part of hypertensive crisis, and in a patient with diastolic dysfunction and etc. But most of the time happens with systolic dysfunction, but there are other mechanisms which also can cause a heart failure. There are 4 clinical entities. You can see the normal patient would be warm and dry. Dry means no edema, and the peripheries will be warm. But in a patient with heart failure, it can fall into these categories. Patient can be warm, the periphery is well perfused, but edematous. We call it warm and wet. A patient can be poorly perfused, due to poor cardiac output, but not edematous. We call it cold and dry. That means peripheries are warm. The worst situation is cold and wet, where the peripheries are cold, poorly perfused, and the patient is edematous. That's cold and wet category. That is the category which is very difficult to deal with. You need to perfuse the organ and also to reduce the edema, which can be more challenging. So for a patient with acute heart failure, there are three supports we can provide to the patient. We can give support to assist with the ventilation and oxygenation. We can use pharmacological support to enhance tissue perfusion, to get rid of the edema, as well as improving the symptoms. So these are the two main arms, but in certain situations, especially in better developed world, where with additional facilities, we have mechanical circulatory support to augment cardiac pumping function. So while we give all these symptomatic medications with different medications and ventilator support, we also need to act in parallel to address the etiology. For example, if a patient has heart failure due to acute coronary syndrome, we need to open up the vessel and establish improved cardiac function so that we are addressing the primary issue while giving the supportive care to the patient. So if the patient has a hypertensive, emergency, you need to control the blood pressure. If this patient is having arrhythmia like a VT or something, you need to revert it to help the heart failure in addition to the supportive care, right? So in a patient with infection, you need to treat that. There's a tamponade, you need to drain it. Likewise, you need to, while you give the supportive care, look for the cause and treat the specific cause, which is equally important. So with regard to patient management, with regard to ventilator support, you would always prop up the patient if the blood pressure is permitting. We will not be using oxygen routinely. It causes vasoconstriction, reduces cardiac output. So you would allow a little bit of hypoxemia is okay, provided the saturation is over 90%. If the saturation below 90%, then you need to give oxygen, support the patient. In a patient with COPD, even saturation of 88 would be okay. But you don't want to make sure, don't want to overtreat and get a saturation of 100. So in a patient with saturation dropping below 90, I would give oxygen, getting saturations up to around 96% would be perfect. So don't overtreat. Don't always try to get saturation of 100% in every patient, right? So with regard to non-invasive ventilator support, CPAP or a BiPAP is preferred because that will increase the intraalveolar pressure, prevent further pulmonary edema developing. So it is preferred in a patient who is breathless, respiratory over 25, saturation less than 90. It will reduce the chance of endotracheal intubation, but it can drop the blood pressure slightly, so you have to be very cautious in a patient with hypertensive. But this is one of the main arms which is very, very, very useful in a patient with pulmonary edema. But those who do poorly tolerate CPAP due to worsening altered mental state or having a worsening blood gas parameters, dropping saturations, becoming acidotic, you need to go for invasive ventilator support. So what are the pharmacological support we can offer in acute heart failure? We can use IV diuretics, which is one of the main cornerstones in patient management. We can use vasodilators if the blood pressure is too high, but we don't want to drop it too rapidly, too low, and worsen the coronary ischemia. Inotropic support is useful in those who are having a low cardiac output, especially useful if your patient is having cold peripheries, to perfuse. If the patient is having arrhythmia, we can, for example, atrial fibrillation, we can use medication to control the heart rate like digoxin. Should use medication to prevent thromboembolism like DVT prophylaxis. We don't routinely recommend use of opioids like morphine for patients with heart failure because it will worsen the rates of invasive ventilation. So you would try to manage with ventilator support or the CPAP, the diuretic, the oxygen, and try to manage the patient with that. You will advise all reduction to the patient as well. With regard to dosing of loop diuretics, we would give for patient with acute heart failure. If the patient has not been on a oral diuretic, so we can try with about 40 milligrams of IV furosemide. But if the patient has been on a oral diuretic, you can go double the dose of furosemide given as intravenous to get more effective diuretics. So while you give the bolus to have quick effect, for the maintenance effect, you can go for a continuous continuous infusion that will prevent rapid drop in blood pressure. But you will need to give an initial bolus because continuous infusion will take time to take effect. While you diurese the patient, you will have to monitor the patient's urine output and see if the output is adequate. If it's not adequate, you can repeat the IV laxis in about a couple of hours. And when you get the adequate output to around, about close to around 100 ml per hour, then you can maintain with the infusion, or you can give a regular dose in about 12 hours time. But if the poor output, the output is still low, you may have to repeat the doses early. But you will have to monitor the patient's electrolytes, especially potassium levels as well as magnesium levels. Watch out for worsening of renal functions because diuretics will deplete the intravascular volume, sometimes can cause acute renal impairment. So IV vasodilator therapy is used in those who have very high blood pressure, 160. Try to get the blood pressure down to a reasonable level and help with patient management. So these are some of the inotropic supports which we will use for the patients. You can use dobutamine as a first choice, provided the pressure is not too low. Then other medications like dopamine, milrinone, enoximone, levosimendan, norepinephrine, and epinephrine are some of the medications which are used. So there are a few flow charts which are there, but basically the management is the same as I specified. Thank you. It's open for questions. I have not covered the entire spectrum of cardiac emergency. It's so vast. So just some of the common things and some of the essential things, especially precautions we have to take in managing, and certain high index of suspicion which is required, especially for a STEMI. I just want to emphasize in this lecture.
Thank you very much, sir, for that very comprehensive but very concise presentation. So we have received about 150 questions today. We are not going to move on and look into all the questions. We will try to figure out some of the areas which are not captured in the presentation. So I'll move on to some of the questions which have been posted on the chat, sir. So first, they have asked, are our IV fluids contraindicated in hypertensive urgency or hypertensive emergency?
I wouldn't say it is contraindicated. It probably will worsen the hypertension, but when a patient, for example, if you got a hypertensive emergency with worsening renal functions, once your blood pressure is controlled, you may add to maintain tissue perfusion. I would not use IV fluid all of a sudden, but I would just get the blood pressure to a reasonable control range. And then to support the kidney, I still should be able to use it, but I will not use it in a patient who's having a still blood pressure of 200. I would just use vasodilators, get the blood pressure down to reasonable level. So if I want to use IV fluids to perfuse the kidney, I would use it after that.
Right, sir. And also another question, in end-stage kidney disease, most patients have systolic blood pressure more than 180. So what is the consensus on the rate of reducing their blood pressure?
Sorry?
Mostly end-stage kidney disease patients have the systolic blood pressure of more than 180. So what is the consensus on the rate of reducing their blood pressure?
If it's a established CKD, no acute worsening of renal function, it is not really a hypertensive emergency. So you can call it a hypertensive urgency where you will not be using IV medication. You'll be just managing with oral medications. and try to get the blood pressure down slowly over 48 hours or so. So you'll not be dropping the blood pressure suddenly unless you have, creatinine going up from 3.3 to, 4.5, 5.9. That's a acute progressive deterioration of renal dysfunction. That is the proper hypertensive emergency where we'll get the blood pressure 25% reduction over the first 1 hour, then up to 160 range, then maintain that for about 24. That's in acute worsening of established renal function, which is different from a patient who has, stable function with a high blood. That's a hypertensive urgency where I'll just be using oral medication, getting the blood pressure down to my desired range, even up to 140, 130 over the next 48 hours or even longer periods. So I'll just be using oral medication. I will not be going for rapid reduction of blood pressure.
All right. And then the next question is, when should we do the troponin level? Because they have asked, is it worth doing troponin I as soon as the patient comes with cardiac, like the chest pain, since it could still be low at that point?
Yeah, you can use the troponin immediately, but you will have to repeat it if you're using a highly sensitive troponin, repeat in about 3 hours. So ideally, to baseline plus 3 hours, and you look for dynamic changes and try to make early diagnosis. But again, which is why I said troponin will take time. Even your ECG changes will take time. So first prioritize the clinical history and the setup here where you treat the patient. So if the patient has, suggestive history of acute coronary syndrome, I will not wait for any change. I'll be doing a quick ECG. But if the patient has ongoing pain, I'll be just think this is unless proven otherwise, this is a STEMI, you send the patient to emergency department and do the evaluation there, do an echo, make a quick diagnosis if the patient is unwell. So troponin as well as the repeat ECGs are, essential, valuable tools. But sometimes if the patient's clinical conditions demands urgent action, you will use for quicker tools to make a quicker diagnosis. Do an echo, look for regional low motion, try to immediately activate the cath lab with this regional low motion. So it's clinical evaluation first, tools supplementary, troponin can be done, baseline in 3 hours. As per the sensitivity of the kit, there are specific protocol is mentioned. You follow the protocol, but you can do it. But only thing in our setup where the cost is involved, you would like to do one troponin that can be there. But always look at the patient's history and the clinical situation. If he's in agony, in pain, unless proven otherwise, consider this could possibly be a STEMI. Just sent to the places where there is emergency, assessment and the treatment tools are available. So the patient gets quicker treatment and a survival benefit.
Okay, so thank you. And the another question that we have received is, what is the antihypertensive choice in ICH? Is it IV labetalol or IV nicardipine?
IV nicardipine.
All right. Then they're asking about the STEMI management. So what are the alternatives for aspirin for a patient with allergy to aspirin?
Well, that's a good question. If your patient is allergic, then it's going to put you in a difficult scenario. I actually would like to give IV ticagrelor in that type of a patient, and it's going to create enormous challenges, in treating the patient. If the patient is allergic to aspirin with a mild urticaria, we can consider certain management tool. But in a patient with a STEMI, you have to make quick judgments and quick treatments. So we may have to consider something like ticagrelor. But again, if you're given ticagrelor, you can't. That's a difficult scenario. I will have to have another thought whether to consider just give clopidogrel and consider thrombolysis one option. That's one option.
All right.
Other option is to go for ticagrelor, then taking 2 primary PCI, then again on one antiplatelet therapy doing a procedure also has a concern. So it would push me to a situation where I'll have to take less ideal treatment solution for the patient. But those are one option. Just go for clopidogrel and go for thrombolysis on single antiplatelet is probably one of the ways to manage. If I end up the patient with the cath lab, I might have to do it on ticagrelor monotherapy. Then I will have issues, but there are new treatment options which are available, like not putting a stent, maybe bailing out with a drug-coated balloon, just open up the vessel. That's probably something I would consider. So it will push me to a corner where I'll have to make a subjective judgment, not in a not so ideal way.
Okay, so and another question that we have received is whether you can explain briefly the pathophysiology behind thrombolysis in LBBB, the left bundle branch block.
Yeah, that's again an excellent question. So LBB, you will use again one of the most number one thing for me is the clinical presentation. Is the patient having anginal pain? I would consider that as a STEMI. Number two, there are other ECG tools which can be used, like using the Garbosa criteria. Now, in a patient with LBB, always you will have a bit of ST elevation. Very often in the anterior lead, you will see the QRS, complex downwards and a little bit of ST elevation in the opposite direction. We call it discordant ST elevation. Now, about 1 or 2 boxes or even 3 boxes can be normal in a normal LBB. But if it's this discordant elevation is more than 5 small boxes, we call it significant. It can be a Garbosa criteria significant point in making a judgment of STEMI. But if you got in any lead, for example, lead 1 or a V6 where the QR is upright, if you got even 1 millimeter of ST elevation, we call it concordant ST elevation. That is itself is very significant. So discordant elevation more than 5 millimeters, concordant ST elevation or concordant ST depression where the QRS, STs are both in the same directions. Even 1 millimeter concordant is significant, discordant more than 5 millimeters is significant. But again, all to do with the clinical history, how's the patient's clinical picture? Is the patient in a pain with angina, or is he having a heart failure, hypertension? Usually LBB indicates a large area of infarct. So patient very often hypotensive, very often in failure, in agony, in pain. I would just activate the cath lab and try to do a primary PCI if feasible, or else thrombolysis. So Garbosa criteria useful, but clinical picture is even more important in making a judgment.
Right, so thank you. And another question that we have received about the acute heart failure. In a patient with acute heart failure and in cardiogenic shock, is it possible to use IV diuretics as a bolus or an infusion? So another one has asked on using IV furosemide, whether it's better to use it as an infusion or as a regular bolus dose.
Yes, in a patient with hypotension, you can have worsening of the hypertension because of the diuretic, but also you don't want the patient to be hypoxic and in pulmonary edema. So you'll have to strike a balance. In a patient with hypotension, you will have to support the patient with inotropic support. You may have to use dobutamine, but the blood pressure is too low. You may have to support both norepinephrine and dobutamine, get the blood pressure up. You will be using a slightly lower dose of IV diuretics. Infusion is great, but infusion will take time. For example, if you're using 5 milligrams, so it will take 4 hours for the 20 milligrams to be delivered. So you may have to use a lower bowling dose of initial dose of IV furosemide, then maintain with the infusion, preferably try to support the blood pressure with inotropes and strike a balance. It's a difficult situation to treat, but you will have to use diuretics if the patient is hypoxic, but you will have to support the blood pressure with inotropic support in parallel. More importantly, treat the primary cause for the heart failure. If it's MI, you need to treat it. Sometimes you might have to use balloon pump. Sometimes you will have to take the patient to cath lab. So you'll have to support the patient in multiple ways, but it's going to be a high risk situation in bailing out the patient.
Thanks. And another question that we have received is whether we can initiate or continue beta blockers in acute decompensated heart failure.
Well, in a patient, if the patient is hypotensive, you might have to stop it. But if the blood pressure is permitting, you will go for a dose reduction in acute heart failure. If the patient is on a normal dose, you might go for a half dose reduction if the blood pressure is permitting, rather than suddenly completely stopping it. But in a patient with hypotensive, poorly perfusive, you may have to stop it temporarily.
Right. And another question is on acute coronary syndrome. So what is the duration of enoxaparin in acute coronary syndrome?
It varies. You can go up to 5 days or even longer in patient with evidence of high thrombotic burden, but generally it varies from 2 to 5 days. You could use it based on the clinical scenario. Then sometimes you'll have to manage the patient load as well. So it varies. Minimum 2 days, maximum 5 days or 7 days.
And they have also asked about the best time frame to do the troponin, whether is there a time frame that you need to go with.
Yeah, you just do the baseline and maybe 3 hours as per the kit tool, protocol demands. As per the sensitivity, there are specific protocols in each hospitals. So you'll have to use the protocol. So ideally 2 baseline and about 3 hours, highly sensitive. Look for dynamic change. And it is more useful for discharge planning as well in those setups.
And also about atorvastatin use, sir. What is the atorvastatin loading dose? Is it 80 milligrams or 40 milligrams?
It's 80
also,
milligrams.
they have asked about an elderly patient complaining of high dose of atorvastatin and erectile dysfunction. And in such case, how do we solve the issue?
Well, atorvastatin and erectile dysfunction is something I need to search and find out. I'm not entirely sure about the link. Perhaps question I need to find the answer to myself as well.
All right, sir. And then the drug of choice in aortic dissection, whether it's nicardipine, if nicardipine is not available, then what is the next?
Aortic dissection, is it?
Yes, sir. They have asked about aortic dissection.
Aortic dissection, I said the medication of choice is a beta blocker, isn't it? Aortic dissection is IV labetalol or IV esmolol.
Okay, sir. And I think we have answered many questions as we could today. And so we keep on getting questions. So it seems like the lecture was very interesting. And I hope most of you posted questions have found the answers. And so with that, we have come to the end of our CBD session for today. So we would like to thank Dr. Amila Walawwatta, the consultant cardiologist from the Colombo South Teaching Hospital. So thank you very much, sir, for that enlightening and very thought-provoking presentation on common cardiac conditions. So the topic, as we could see, was very highly relevant, but also incredibly timely. And we had very clear explanations and practical insights from you, which have greatly enhanced the understanding of our participants. And so we would sincerely and gratefully like to appreciate your time and expertise. And on behalf of Shri, we would like to thank you for your long-standing association with Shri and your continued commitment over the years in enriching the knowledge and and the growth of our members as well. And thank you, sir. And we hope that you would continue to engage in Shri's CPD sessions in the future as well. And with that, we would like to move on to the ending of the CPD session. So please find the link in the chat box and kindly give your feedback and answer the post-assessment questions, and you will be receiving your e-certificate for the participation for the CPD session conducted by Shri, the Society for Health Research and Innovation. And you would have access to this presentation in our YouTube channel in Shri CPD Growth Academy. And so with that, we would like to continue the webinar series today. And we wish you all a very good day and a very long weekend as well.